Hello everyone, welcome back to my channel. So we are going to start with a new chapter, that is your regressive alterations. In this is a very minor chapter but has been come as a 5 marker, 10 mark, not a 10 marker, 5 marker, 2 marker. So we're going to finish this chapter in one video. So it's going to be a short video and I'm going to cover everything in this. So stay tuned and let's begin. So regressive alterations. First is abrasion. So basically regressive alterations are the alterations of teeth with age. Okay, so as age progresses or because of some physical factors, pathological factors, how the size of the teeth or the shape of the teeth is altered. So that is regressive alterations. Let us start with abrasion. So what is abrasion? Abrasion is defined as the pathological wearing away of tooth substance through some abnormal mechanical process. Okay, so this is the pathological wearing of the tooth surface through some abnormal mechanical process. The occurrence of facial surfaces of crown and exposed root surfaces of teeth. So basically what is abrasion? Abrasion is the pathological wearing away. Okay, so the tooth surface is worn off through some abnormal mechanical process, that is abrasion. Okay, so where does it mainly occur? It is seen in the facial surfaces of crowns, exposed root surfaces of teeth, and under certain circumstances on the incisal and the proximal surfaces as well, but mainly on the facial surface of the anteriors and the exposed root surfaces of the posteriors. Okay, okay, so the etiology is most common cause of abrasion is dentrificis. Okay, what is dentrificis? Dentrificis is nothing but your toothpastes, okay, and your brushing techniques. So the two main causes of your abrasion is your dentrificis and your brushing technique. Anyhow, modern dentrifices are not sufficiently abrasive enough to damage the intact enamel, but they can cause remarkable wear in the cementum and dentin. Okay, so dentrifices do not cause so much abrasion in the enamel, but they can cause a remarkable wear of cementum and dentin. Now, if the toothbrush carrying dentrifice is indigenously used in a particular way, that is, if a toothbrush is used more horizontally than vertically, in such cases a clinical manifestation, that is your V-shaped notch or a wedge-shaped ditch, is seen on the CEJ of the teeth with gingival recession. So let's just say this is the teeth. I'm drawing a incisor. Okay, so if this is an incisor, the root surface of the incisor, the wedge shaped ditch on the root surface of CEJ with the gingival recession at the angle formed at the depth of the lesion as well as the enamel edge. So the lesion is usually formed here at the cervix of the crown and the beginning or the CEJ of the root. There is the lesion, which is V-shaped lesion. It is usually like this. Okay, V-shaped lesion or ditch on the CEJ in teeth with a gingival recession. The angle formed in the depth of the lesion as well as the enamel edge is sharp. Now exposed dentin appears highly polished. The abrasion is more common on the left side of the mouth. So people with right hand side brush more towards the left hand side. So the left hand side enamel is worn off more, and if people are left hand sided, then they use their right hand, then they brush their right side more. So left-handed people brush more on the right side, and right-handed people brush more on the left side. So because of which there is a decrease in enamel surface and exposure of dentin in both the sides, and sometimes cementum if there is gingival recession. Now it is mainly located in the cervical areas of the teeth. Okay, cervical areas it is seen in and lesions are more wider than deeper. So the lesions are more wider than deeper. Premolars are more affected, and cuspids, that is your canines, are more affected, right? Coming to the other forms, cuspids include everything, okay? And the other form of abrasion could be due to habit, occupational, that is your opening of bobby pins. So tailors usually keep the needle of the sewing machine or the needle of the bobby pin in their mouth, especially at the incisors. They hold it, so there is a depression or a notch in the incisal edge, okay, of the incisors. This notching is usually seen in tailors, and that is an occupational abrasion. Then similarly, notching could be seen in carpenters, shoemakers, and your proximal root surface is also abraded in use of specific dental aids such as flossers. Use of tooth breaks could also cause abrasion of the proximal root surface. Now coming to the pathogenesis, unlike varied etiology, pathogenesis remains identical to all. The dentinal tubules are exposed, leading to irritation of the odontoblastic process. The odontoblasts stimulate secondary dentin formation. Secondary dentin protects the tooth from pulpal exposure. So there is a formation of secondary dentin. The secondary dentin protects the tooth from pulpal exposure. Then treatment is proper brushing technique and use of milder abrasives, right? So the pathogenesis is basically when the enamel abrades, there is exposure of dentin. The dentin does not directly accept these stimuli. It causes the formation of secondary dentin. The secondary dentin protects the pulp. Okay. Now coming to erosion. Erosion is the the chemical loss. So the pathology or the etiology for erosion is your chemical process. Okay. So dental erosion is defined as irreversible loss of dental hard tissue by chemical process that does not involve bacteria. So any chemical process other than your bacteria is erosion. Okay. So dissolution of mineralized tooth structures occur on contact with aids that are introduced into the oral cavity. So basically, if there are any gastric, esophageal refluxes or vomiting, these produce acidic environment of the oral cavity, leading to erosion of the enamel. That is your intrinsic, because it is coming internally, and there is another extrinsic, which is your acidic beverages or citrus fruits, which are taken externally, causing the extrinsic erosion of the teeth. Now moving forward is your abfraction. Abfraction is a mode of tooth loss with clinical and circumstantial evidence of So basically, a mode of tooth loss with clinical and circumstantial evidence derived from Latin. Ab means away from, fraction means to break. So the etiology is due to occlusal compressive forces and tensile stress. So basically, abfraction is loss of tooth structure with clinical and circumstantial evidence. Now, etiology could be due to occlusal compressive forces, tensile stresses, masticatory stresses, chemical, swallowing, clenching. Wherever you cause a lot of tooth flexions or tooth movements, the tooth tend to microfracture. That is your abfraction. Okay, abfraction is basically a kind of tooth fracture which is occurring due to stress and compressive forces. Okay. Now, repeated flexure or the tooth movement causes microfractures of the hydroxyapatite crystals in the enamel and dentin, leading to breaking away from the crown. More deformations occur at the cervical end due to low packing of the density of Hunter-Steger bands. Okay, so in the cervical end, the packaging of the Hunter-Steger bands of the enamel is less, resulting in material fatigue of tooth structure. Now coming to the location, mainly in the gingival third of the crown, usually on the buccal surfaces. Okay, so it is located in the gingival third of the crown, and in the buccal surfaces, usually seen as a wedge-shaped lesion in the cervical area, common in premolars and molars. Treatment is dietary habits, brushing, night guards, counseling the patient, improving chewing habits. If there is any malocclusion, correcting the malocclusion, restorative procedures. Now there are two more important things, that is your dentinal sclerosis and your hypercementosis. First we will see what is dentinal sclerosis. Dentinal sclerosis is a regressive alteration of dentin characterized by calcification of dentinal tubules. So there is calcification of the dentinal tubules which occurs due to the injury of dentin. If there is any injury of the dentin gets sclerosed or calcified. Okay. Then this is a normal aging process. Deposition of calcium salts within the dentinal tubules is a most likely source of calcium, and dental lips is the most likely source of calcium. Okay, and then which leads to increased mineralization of dentin. Occlusion of dentinal tubules reduces conductivity to odontoblasts and appearance as a translucent zone under transmitted light seen beneath shallow carious lesions. The difference is in the refractive index between the sclerotic and the normal dentinal tubules. Okay. Now, what is internal resorption? Internal resorption is an unusual form of tooth resorption that begins centrally within the tooth, occurs due to a peculiar inflammatory hyperplasia of pulp. Internal resorption is an unusual form of tooth resorption. Okay, so internal resorption is an unusual form of tooth resorption that begins centrally within the tooth. Okay, it begins centrally within the tooth, right? Unusual form begins centrally within the tooth and then occurs due to a peculiar inflammatory hyperplasia. Then the pulp starts growing, hyperplasia of the pulp occurs, and this is your internal resorption, right? Now etiopathogenesis is its etiology is unknown. So there is a hyperplasia of the pulp. Usually pulp hyperplasia could be due to a bacterial infection or your dentinal caries. Okay, so but here we say it is idiopathic because hyperplasia could occur because of several reasons. Now sometimes associated with, as I said, caries exposure, pulpal infection, chronic pulpitis. Okay, now there is granulation tissue invasion could also be seen. Now pathogenesis is chronic inflammation of pulp leads to formation of granulation tissue. Granulation tissue activates the osteoclasts. Osteoclasts resorb the inner surface of the tooth, that is the internal dentinal walls, which leads to the hyperplastic pulp, and the enamel starts becoming thinner and thinner and the tooth becomes more pink, and it is usually asymptomatic, and the pink hued area on the crown of the tooth is called pink tooth of Murmury due to hyperplastic vascular pulp seen through thin enamel. If the lesion occurs at the root, there are no obvious signs. Now the tooth involvement is mostly incisors, canines, premolars, molars. Radiographically, round ovoid radiolucency is the center of the tooth, not related to any external surface until perforation occurs. Okay, next is your histological features: resorption of the inner dentinal surface, presence of lacunae or odontoclasts, proliferation of your pulp tissue, filling the clefts, filling the defects. Pulp shows chronic inflammatory reactions, and alternating resorption and repair, deposition of irregular dentin. If advanced resorption occurs, then dentin may resorb completely. Coronally, enamel resorbs. If it is radicular, then the cementum resolves and result in complete separation of the apical part. Once perforation occurs, it is impossible to determine whether it is external resorption or internal resorption. Then treatment: if it is early, then you do an RCT; if it is late, then an extraction. Now coming to hypercementosis, same like your dentinal sclerosis, there is hypercementosis, which is characterized by, there you had calcium salt deposit, here you have cementum deposits on the root surface. Considered as an alteration of the teeth, etiology could be trauma, tooth repair, inflammation, Then it could be the local factors such as accelerated elongation of tooth surface, tooth root. Systemic factors is Paget's disease. Some could be idiopathic. Clinical features is it is asymptomatic. Tooth is sensitive. Okay, so it is usually asymptomatic. Tooth is very sensitive. Pain on percussion is not felt unless and until inflammation is seen. Okay, then next is the extracted tooth. If the tooth is extracted, it is bulky and roots are rounded. Coming to the radiographic appearance, it is roots appear thickened, sharper apex and bulky roots. Histologically, excessive cellular cementum deposition, concentric layers resting lines are seen. It is also called as osteocementum, bone like appearance. Okay, treatment is there is no particular treatment as such, but if there is any underlying infection, then it is usually extracted, but it is difficult to extract. Now coming to one more last topic, that is cementicles. What is cementicles? Cementicles are small foci bodies, small calcified focal bodies in PDL, especially in the lateral and the apex of the root. It is dystrophic calcification which arises because of epithelial cell rests, calcified connective tissue and thrombosed capillaries. May enlarge by continuous deposition of calcium salts, may be free, attached, embedded. Okay, so that is all about regressive alterations. It is a one short video, and if you like it, subscribe to my channel, and for more hit that bell icon, and thank you for watching. Bye bye.